Now, please welcome your host for today's webinar, Marlise Perez.
Great, thank you so much. So I am Marlise Perez. I am with the Department of Healthcare Services. I am the project executive for our effort around behavioral health transformation. And so thank you so much for joining us today, whether live or just listening to our recording. We're really glad that you're here for this very important topic. I also have with me Tracy Walker, one of my team members that's going to be assisting with this public listening session. So we can move to the next slide and we can just discuss some of the housekeeping. As was already mentioned, this is being recorded. There's also live captioning is available, and there's also some tech support. So if you need any assistance, just put something in the Q&A and they'll be able to get back to you really quickly. And then on the next slide, just want to go over our webinar policies. Just if at any time there's someone being disruptive, we may need to remove them. This usually does not happen, but just want to bring that up. And as already mentioned, when we get to the feedback portions, because that's really what today is all about, is hearing from you on this very important topic. You'll be able to put that feedback in the Q&A, and we'll be reading some of those publicly here, but then we'll be taking all of that feedback as we continue to develop policy around this very important issue. So on the next slide, just want to, as I mentioned, when we get to the feedback, this slide just explains how you put in through the Q&A function. Next slide. One other way that you can provide us feedback as well, as if you're thinking about this over the next few days or you have ideas around this, if you could please send us your feedback to our BHT info mailbox. Any feedback we get between now and August 6th, we will be putting into our summary. If you do provide feedback after that date, we'll still be reviewing it at DHCS. It just won't make it into the summary document. So really encourage you, if you think of other things or just have other examples or ideas, please let us know so we can incorporate that into our policy development. All right, next slide. So what we're going to do is, and you can move to the next slide, is really just jump into this extremely important topic. As most of you know, in California, we have two bills, SB 326 and AB 531, that were passed through the legislature, and then were moved on to the March 2024 ballot, which then was approved by the voters. And there's really two big pieces, is the Behavioral Health Services Act, which is what we're going to talk about today, and then also the Behavioral Health Infrastructure Bond Act, which we have talked about in prior listening sessions. So on the next slide, what we want to do as we are looking at all of the development around the Behavioral Health Services Act and this extremely important topic around substance use disorders and integrating that into the Behavioral Health Services Act. First, what we want to do, though, is just set a little bit of a groundwork and a framing of the type of funding that we have in California for substance use disorder services. And so our county behavioral health departments, they receive funding from us at the state level, federal level, and then other sources of funding to provide substance use disorder services. And so each funding source has multiple different requirements that the counties must follow. And so this could be around who they can serve, what type of allowable expenditures, the timeframes of expenditure. Some have very exact timeframes in which the funding has to be spent. And then, of course, different requirements around how to apply for the funds and then how to report the data that is being utilized for that funding. And so what happens a lot at the local level is counties will utilize these various funding sources in order to provide the most effective and efficient services at the county local level. And so we really just wanted to walk you briefly through some of these funding sources, as these funding sources are also a part of the behavioral health transformation. So on the next slide, just really want to first talk about Drug Medi-Cal. And so Drug Medi-Cal is an entitlement for those Californians that live in our great state. And so Drug Medi-Cal is providing, you'll see here, There's 19 counties that have what we call the Drug Medi-Cal State Plan. And then I'll talk in a moment about our other counties and the efforts that they're utilizing with the Drug Medi-Cal organized delivery system. But you'll see here on this map that 96% of our population is actually being covered under the Drug Medi-Cal organized delivery system. And this really is expanded set of services. And you can move us to the next slide that just really demonstrate. On the left here, you'll see the Drug Medi-Cal benefits. That's with our currently 19 counties. And then the Drug Medi-Cal organized delivery system really expands out what is available for individuals that have a substance use disorder. And so with that, any of our Medi-Cal beneficiaries that are eligible in California to receive substance use disorder services can receive these services, once again, depending on which county that they're residing in. And then on the next slide, we also have had over the last several years opioid settlement funds that are coming into California. These are funds that are through whether it is a settlement agreement or a bankruptcy, funding that is coming in to remediate the damage that has been caused by the opioid epidemic and by various entities that have been found through the court to have shown cause. And so you'll see here, there's many different types of settlements and also bankruptcy funds. The majority of these funds go to the local level, and our department actually oversees to ensure that the counties and cities are utilizing this funding for opioid remediation. And on the next slide, we also have some federal funds that come into California. It's called the Substance Use Prevention, Treatment, and Recovery Services Block Grant. And so in California, we receive an annual allocation of about $230 million. And the majority of this funding goes down to the local level. And this is funding that is used for various services. You'll see here at the bottom of the screen, there is a part of this funding that can be used what we call discretionary. And so that's really based on the local need. There's also funding that is designated for perinatal, which could be women and or their children, also pregnant women. And then for prevention services, and then also for adolescent and youth services. Next slide. So with this federal funding, the sub-G funding, as I mentioned earlier, there are different categories of how the funding can be utilized. And then there's also funding areas where counties must utilize the funding in order to serve special populations. Next slide. There's also in California, in 2011, there was what's known as realignment. So there was Senate Bill 1020. And what this did is it created this realignment of funds that were previously overseen at the state level down to the county level. Some of you may know this as it created the behavioral health sub-account. You'll see here there are mental health dollars, but there's also substance use disorder service dollars. And those are around drug Medi-Cal, residential perinatal drug services and treatment, and drug court operations. So these funds just are at the local level for county partners to utilize. And so with that, I do just want to move to our next slide and open it up for our first question for feedback. We would like to know, how can DHCS assist stakeholders in understanding the requirements, limitations, and opportunities of the various county funding sources for substance use disorders? And so if you could just put your feedback in the chat, that would be great. And as we begin receiving that, like I mentioned, we'll be calling some of it out, highlighting some of it. But once again, we will be collecting all of it and utilizing it as we further develop not only our policy around behavioral health transformation, but also our technical assistance.
And just to clarify, you can put it in the question and answers, not the chat. Thank you. We have one suggestion to send out a survey to harm reduction programs in counties. Also another regarding fact sheets or some kind of resource guide. Additionally, webinars like this and deep dives for conversation roundtables. Information can be provided at family resource centers. We have a suggestion to use plain language when we're describing requirements and limitations and opportunities. As well as newsletters, announcements, and email communications.
I'm also seeing, looks like it'd be helpful to have some clarity around which individuals responsible dispense the funds for the different groups. So individual stakeholders know where to direct their requests. I'm also seeing a lot around widespread education that destigmatizes substance use.
There's a suggestion for 211 to provide information like this to callers.
Great, and I'm going to wrap up this here with this last comment around training the counties on what funding is available to them as well. So please feel free to continue to put your feedback into the Q&A portion. We'll be, like I said, reviewing all of it, but I do just want to move us forward in the webinar because we have a lot to cover today. And really the primary focus of this webinar is how substance use disorders is being integrated into the Behavioral Health Services Act. And so you'll see here in the legislation, there is what we call intent language, and this is really what guides the legislation. But you'll see here in the intent language, 1 in 10 Californians meet the criteria for a substance use disorder. There's also a lot of statistics around how many individuals are moving through our emergency departments, how that has increased, especially with the opioid epidemic. And then on the next slide, just really showing that, you know, substance use disorders, while we've obviously been having issues here in California for many, many years and continuing to unfortunately increase in certain areas, the focus here around putting it into the Behavioral Health Services Act was a key focus of the administration in order to allow these funds to be utilized for treating a substance use disorder. And you'll see here the definition around that. And it is, you know, including harm reduction, treatment, and recovery services, as well as Federal Food and Drug Administration approved medications. And so I'm just going to walk you a little bit through what each of these definitions mean. And I'm going to move us to the next slide. And the first is around harm reduction. And so we are exploring at DHCS because we do have the ability to create the definition for harm reduction. and our federal partners at the Substance Abuse and Mental Health Services Administration, also known as SAMHSA. They do have a definition around harm reduction here, and you'll see it is a lot around, connecting individuals to education, counseling, referrals, making sure that there's overdose reversal medications available, also to lessen the harms associated with drug use, reducing infectious diseases, reducing overdose deaths, reducing stigma associated with substance use and co-occurring disorders, and just really a recognition that harm reduction really is throughout the continuum of care around substance use disorders, and that it really needs to be a big focus for our individuals that are suffering with this disease. And then if we can move to the next slide, for the definition around recovery services, we're exploring aligning the Behavioral Health Services Act definition of recovery services with our current drug Medi-Cal organized delivery system definition. So you'll see here, and we have a lot of information if you want to look at it later, that we have in our state plan amendments, but also we have some policy already set around this definition. But recovery services would include the following service components around assessment, care coordination, counseling, family therapy, recovery monitoring, and relapse prevention. And then on the next slide, just really want to go into a little bit around where substance use disorders is in through actually it's all throughout the Behavioral Health Services Act. And so a few things here is that counties are going to be utilizing data at the local level to allocate the BHSA funding between mental health and substance use disorder treatment services. And then also, the reason I walked you through those other funding sources at the beginning of this presentation is the counties are going to be submitting an integrated plan to us. And if you want more information about that, we do have a previous public listening session I'd encourage you to listen to. But it will be detailing out all of the funding sources that counties receive for substance use disorders and also mental health. And so they're going to be showing us how they are aligning the utilization of these funds, but also with the local need. And then you're also going to see here, they're going to be addressing SUD disparities in this integrated plan. And then just a note for those counties that have separate mental health and SUD departments, they're going to be working together to submit one integrated plan for their county. Next slide. And then also just want to point out that this BHSA funding can also be utilized by counties as the federal match for drug Medi-Cal and drug Medi-Cal organized delivery system services. And just as a note, currently counties spend about 12% of their total Medi-Cal behavioral health treatment dollars on SUD. So this is suggesting that there's an opportunity here to increase services for SUD utilizing BHSA funding. And then also for SUD services that are not covered by Medi-Cal, recognizing that not everyone in California has Medi-Cal, this BHSA funding can be utilized to treat individuals with moderate to severe conditions. Also, if we go back, thank you. Also that we just want to highlight that we are looking at utilizing that SAMHSA harm reduction definition as a framework, as well as the recovery services as a definition framework as well. So with that, I do want to move us to our next question for feedback. So just in what I was explaining, do the SUD and BHSA items resonate with you? What would you add or change? So just want to open this up for feedback and see what, and this could be around the definition of the harm reduction or recovery services as well, but just to see what type of feedback you have around this general framework that we just presented. I'll start with the first comment that I see. This individual would like to see more integration of mental health and substance use disorders. Someone else, they appreciate SAMHSA's harm reduction definition. And then just a note of clarification, BHSA funding does not include people with mild SUD. It's just moderate to severe, and that is based on the DSM criteria.
There's another suggestion about including language around low barrier treatment access as part of harm reduction. We have agreement with breaking down the silos between mental health and SUD.
There's also a request if maybe Emma, can you move back just one slide so folks can see that as they're putting in their feedback? That'd be great. Thank you.
We have several comments about the harm reduction alignment and adding harm reduction, especially for those that are experiencing homelessness and for youth.
Just a call out here too around dual diagnosis. That is still an allowable utilization of BHSA dollars as well. I know we're focusing primarily on an individual with just a substance use disorder, but these funds can also be used for that purpose as well.
We have several comments about some of the difficulties of clients or individuals that are seeking services that have a dual diagnosis, and this breaking down of silos and barriers between those two would be very welcome and helpful.
Yeah, a lot of comments around dual diagnosis and the number of individuals that the comments I have been reading around how they're being served, and just really some issues around understanding which funding source to utilize, and then also the resources available. And so with that, I'm just going to move us on. Once again, I want to thank everybody for all their feedback. Please continue to be putting it in the chat, or the Q&A, excuse me. Just because we're not reading it doesn't mean out loud that we're not going to be looking at it. So it's very important. So thank you for that. So what I want to move us on to next is around what is happening with the planning process at the local level. And so in the new legislation, there are requirements from various SUD stakeholders must be a part of the local planning process. And so you'll see here the addition of very particular SUD stakeholders that have to really be at that table. And if you want that list, it's actually in our Welfare and Institution Code, and here's the citation. There's also at the local level currently a mental health board, but now this changes the requirement to be a behavioral health board, which means there has to be representatives from the mental health and substance use disorder fields. And then also with our Behavioral Health Services Oversight and Accountability Commission, there are new members that are required to be added to that commission. Next slide. And so I touched on it briefly, but just want to reiterate really quickly around this integrated plan for behavioral health services and outcomes. This is a 3-year plan. The first one is due to the department June 30th of 2026, and it's a plan for every 3 years. This is really a prospective, data-driven plan that also have projections around the budget and all of those different funding source categories that I mentioned earlier, along with, of course, BHSA. Next slide. And so really just want to talk about a little bit around the expanded focus of the integrated plan. This is really to get a look at across the behavioral health funding sources, how counties are planning to utilize these funds to increase transparency and accountability in county reporting, and really to ensure that counties are efficiently utilizing their behavioral health funding. There's also going to be a lot of data analysis across counties, services, and funding streams in order to identify gaps in service delivery. And so on the next slide, there's also in this integrated plan, counties are going to have to be having their service activities and their expenditures for not only mental health, but also substance use disorder services. And so you'll see here, these are the funding streams that counties will be required to report to DHCS through that integrated plan. And once again, you'll see the ones that I already mentioned around substance use disorders. Next slide. And then also, there are other provisions in BHSA around SUD for treatment services for children, youth, adults, older adults. And so, as I mentioned earlier, that when providing substance use disorder treatment services, all forms of FDA approved medications for addiction treatment must be provided. And then also, counties can utilize the BHSA funding to assess whether or not an individual has a substance use disorder and treat the individual prior to a diagnosis. And then also, as I mentioned, that counties will be including substance use disorder treatment services in the integrated plan, and then also in their annual updates. Next slide. Also, the funding, if you're familiar with BHSA, there's 3 buckets of funding. And one of the funding buckets is around housing. The second is full service partnership. And the third is behavioral health services and supports. I'm going to touch on each of these and how SUD is integrated into all 3 of these buckets. And so once again, what the BHSA funding allows counties to do is utilize BHSA funding to support these services, either just with BHSA or also in conjunction in combination with those other funding sources that can be utilized for these SUD services. And then also outside of DHCS, there are other state-directed responsibilities that come from Proposition 1 under BHSA, and that is around population-based prevention, which is being overseen by our partners at the Department of Public Health, Workforce, which is overseen by HCI, the Innovation Partnership Fund, which is being overseen by the commission that I mentioned earlier as well. So all 3 of these entities will be conducting stakeholder feedback and reaching out around how SUD will be an aspect of all 3 of these initiatives as well. Next slide. So something else that the counties will be required to provide to DHCS is the Behavioral Health Outcomes Accountability and Transparency Report. And so really what this is kind of a mirror to that integrated plan. So the counties prepare the integrated plan of what they're planning to utilize the funds for, and then the voter is a report out of how the funds were actually expended. And you'll see here that voter is going to have for mental health and substance use disorder expenditures and activities. And then we at DHCS will use all of the counties' submissions of their voters, and we will be putting out a state report so everybody can see what is happening with these funds. Next slide. There's also, as a part of this legislation, a state auditor report. And you'll see here that it's already outlined in statute what areas of priority are going to be contained in the audit. And you'll see here at the bottom, inclusion and impact of SUD services and personnel. Next slide. So as DHCS is developing the guidance around the integrated plan, the BODR, also that planning process I mentioned earlier, and other BHSA policy, what do you want DHCS to be sure to include pertaining to the delivery of SUD services utilizing BHSA funds?
We have one comment about the reporting being uniform across all counties with reporting templates. A suggestion to include prevention services for youth.
I'm also seeing some comments around to ensure that the SUD representation is equal across SUD and mental health as these funds are being planned out. Also seeing just a need for additional awareness about the availability of these services, especially in unincorporated areas.
There's a suggestion about including telehealth access.
A lot of comments around outcomes and what the outcomes should include. And then I'm going to wrap this one up with this last comment around the continuity of care and also case management. So please keep putting your comments in the Q&A, but I am going to move us forward on the next slide because what I want to do is get into, because I've seen a lot of questions filtering through around the 3 buckets that I mentioned earlier. And so I want to just spend a little time on each of those 3 buckets and how SUD is being woven into each of those. And so the first bucket is around housing interventions. And so housing interventions, and you'll see here we cited in the statute where this is contained, but housing interventions are available to individuals with a substance use disorder. So just to answer some of the questions I saw in the chat around that. However, these housing interventions must not deny access to housing for individuals that are utilizing medications for addiction treatment or other authorized medications. And then also housing interventions must comply with the components of Housing First principles, but they may include recovery housing. And so just want to make sure that that's called out. You'll see here we do have highlighted the Housing First principles. We will be providing these slides and post them on our website. So if you want to conduct any more research around some of these principles, we have the link there for you as well. And then the second component is the behavioral health services and supports component. So once again, counties may fund under this bucket the substance use disorder services. This is also where early intervention programs can be funded. And early intervention programs are designed to prevent mental illness and substance use disorders from becoming severe and disabling. So funding can be utilized for SUD in this bucket, Also for outreach and engagement activities to target individuals, and this would include individuals with an SUD as well. And then also in this bucket, there's funding for workforce education and training activities, which also may be utilized to target behavioral health workforce, which once again, behavioral health means mental health and substance use disorder. Next slide. And then the last bucket is around full service partnership. And so full service partnership is really that whatever it takes model. And so programs can utilize funding once again for substance use disorder individuals here for full service partnership. And then also I'm going to talk in a little bit here around a requirement known as assertive field-based initiation for substance use disorder treatment services. And so that must also include the provision of medications for addiction treatment. Next slide. So for these 3 buckets of funding, are there specific areas of guidance that are needed to further develop the use of housing interventions and behavioral health services and support funding to support individuals with a substance use disorder? So just want to open it up for feedback. Okay, I'm seeing some feedback around the early intervention definition, just asking that there's more flexibility, especially around community-defined evidence practices. And then to ensure that counties are funding EI programs for both mental health and substance use.
There's also a comment about adding more guidance on how non-supplantation will work for services that were previously only funded by SUD specific funding streams.
Also, some comments around balanced representation from all SUD levels of care when the local plans are being developed.
Another comment includes making or being more specific about what housing supports are allowable under this funding stream.
Lots of comments around engaging individuals and how that is done and how that is funded.
Another about looking at how BHSA funding and CalAIM funding are supposed to work together on housing and supports.
Yeah, also I'm just seeing a lot around different topics around outcomes, but also data provided at the local level around housing demographics and other demographics of individuals being served. Also seeing around including abstinence-based housing, which is allowable and encouraged under BHSA. So just want to call that one out.
There's a general comment just about there are multiple communities that don't have the resources and infrastructure to provide treatment and housing. So ways to expand both of those.
Great. I'm also just seeing a lot around housing questions in general. I do just want to note we will be doing a different public webinar around the housing. So we'll have a lot more guidance coming out around that housing intervention bucket when we do that public listening session. With that, though, I am going to move us forward into our next section. So I had mentioned one of the buckets is the full service partnership buckets that we like to call whatever it takes. And so within this bucket of funding, as I mentioned, that substance use disorder services can be utilized in this bucket as well. But one of the requirements is around this assertive field-based initiation for substance use disorder treatment services. And so this is a definition that we are looking at utilizing around assertive field-based initiation. And so really would love when we get to the comments to see if this definition resonates for you. But this is really around outreach, engagement, and initiation of medications for addiction treatment in any low barrier setting, such as on the street, in homeless encampments, and in hospital emergency departments to reach people wherever they are. So this is a definition that we are proposing to utilize to define this assertive field-based initiation for SUD. And then on the next slide, I just want to do a little bit deeper dive into what we're looking about for this assertive SUD engagement. And really what we're proposing here is a no wrong door approaching for Californians to medication-assisted treatment. This would be voluntary participation for those that want to be connected into treatment, and that would be focusing on field-based initiation for medications for assisted treatment. It also would include outreach and engagement to individuals wherever they are, as I mentioned earlier, whether on the street, EDs, in syringe exchange programs, homeless encampments, or other settings, to expand low barrier rapid access to all forms of medications for assisted treatment, buprenorphine, methadone, naltrexone. Also to really be, instituting those harm reduction principles for when they are ready to enter into treatment. Also linking to ongoing comprehensive treatment and supports. And that would be with full service partnership, Medi-Cal, or other county programs. And this is once again could be care coordination, primary care, housing, employment. Also to provide flexibility for counties to respond to their local conditions and populations, and then to build upon existing SUD treatment models and programs in California. And then once again, also to maximize available resources, including Medi-Cal, to most efficiently use BHSA funding. And then on the next slide, some of the models that we are potentially looking right now, and this would be a model for opioid use disorders. You'll see here we have some street medicine programs with MAT prescribers in the Bay Area. We also have our CalBridge project that supports 276 hospital emergency departments here in California. Also, the department has just recently awarded $24 million to 32 narcotic treatment programs, and that's to expand their services via medication units and mobile narcotic treatment programs, having methadone available basically, and buprenorphine and naltrexone in these mobile vehicles. So lots of information here around that. We have some new guidance in California that has these the allowance for mobile NTPs, which is really exciting, and then some of the funding that we have been utilizing here at the state level to kickstart these very important resources. There's also been a lot of work around emergency medical services where they're initiating MAT. And once again, you'll see lots of links here. And once we have this posted, really encourage you to look at some of these different initiation models that we are proposing as examples that could be used for this field-based initiation. Next slide. And then also around this proposal, we'd really like to see more access to medications-assisted treatment across California. And so you'll see here, we would like to consider, and this is just a preliminary draft proposal, but that counties could do both of these following. And the first would be to conduct ongoing targeted outreach. And this would be around priority populations, around homelessness, justice involvement, or individuals that are at a higher risk of overdose. Also, it could be, once again, here are just some examples, but outreach could or should include harm reduction kits, naloxone, fentanyl test strips, and xylazine test strips. And then once again, really having these outreach locations where individuals are at, hospital EDs, housing encampments, jails, syringe exchange programs. And then the second is to provide rapid access to all forms of MAT. And that would be having that county programs have the appropriate number of available MAT prescribers, and then being able for our programs that are providing services that either providing MAT on site or having an effective referral mechanism for individuals to receive their medications for assisted treatment. And next slide. And so with this, we also have a draft proposal around connecting into treatment. And so we have these three program components around, number one, providing overdose follow-up engagement services. So after someone survives an overdose, providing that community-based outreach, and then also rapid access to MAT. You'll see here some areas where this is being piloted. And then also number two, ensuring linkages of individuals to SUD treatment and comprehensive services and support after they're being initiated with MAT. And this is around having those warm handoffs, connecting individuals to ongoing treatment and comprehensive integrated treatment. And then the third is integrating and embedding medications for assisted treatment and SUD treatment into those full service partnership teams. And so really making sure that individuals with SUD or co-occurring SUD mental health needs are being met, and then equipping and training staff to provide that whatever it takes to individuals with SUD only or co-occurring as well. Next slide. So are there other suggestions of integrating SUD services into the full service partnership that DHCS should consider? So just going to open that up. If you could put your comments in the chat.
While you were speaking, Marlise, there was some comments that came in that the definition that you had on the slide was good and comprehensive. There was also a question about how FQHCs might fall into the field-based initiations and consideration for those as a means to get folks assistance.
I'm also seeing a lot of questions around some of these models that I spoke about. Is it only BHSA funding that can be used? And just want to clarify, a lot of these models also take Medi-Cal, like the narcotic treatment programs, also the medication units, and the mobile medication. All of those can be utilizing drug Medi-Cal funding, but also BHSA funding. So you'll see there a lot of provisions that we're proposing is to ensure that individuals that don't have Medi-Cal could also be utilizing the BHSA funding in order to receive that level of care as well.
I see a lot of agreement with the current FSP teams that counties already have, incorporating SUD specialists or those that can prescribe buprenorphine in those teams. There's a suggestion that there's some kind of aftercare or follow-up once the medication has been initiated.
Seeing a lot of support around the requirement that the housing has to be supportive of medication treatment.
There's a suggestion that current licensed and certified FSP staff receive SUD-related evidence-based training.
I'm also seeing some comments around, and I've seen it throughout, the value and importance of peers being utilized, just how effective they are in all the levels of care around substance use disorder and mental health. I'm also calling out FQHCs for field-based initiations. Just want to recognize our partners with FQHCs. A lot of them provide a lot of medication-assisted treatment across the state. So that is definitely another great setting for this topic area here. Just also want to call out, because this comment is around alcohol use. I do just want to highlight that some of the models that we've been talking about today are focused around opioid. We are also looking at other models around not only alcohol, but other substances as well. So any feedback around those, would love to hear that also.
We have a comment also about ensuring that services are trauma informed.
Great comment here about proposing to have a co-occurring treatment track in the full service partnerships with the MAT requirement in especially mental health services. And I've seen this comment through some of the questions, but just ways to integrate SUD harm reduction and treatment into the crisis continuums of care. I'm also seeing a lot around staffing levels for SUD at the full service partnership teams. And a lot of comments around all the work that has been done in California in the MAT space, but also we've come a long way, but we've got a long way to go. But just recognizing where we have been moving in California, and a lot of positive comments around that.
We also have a suggestion about creating a safety plan to help clients identify ways to remain sober after initiation.
Also a suggestion of a requirement for services to be trauma informed. more about utilizing peer specialists to help facilitate aftercare and follow-up. Seen a lot of comments around that important service. And with that, I'm going to stop reading out your feedback. It's hard to stop because there's some really great suggestions here. So thank you so much for providing those for us. And I do just want to move to the last few slides that we have in our slide deck today. There is a lot of information that we have on our DHCS website under Behavioral Health Transformation. Once again, we do have our BHT info mailbox. At any time, if you have any feedback for us or any questions, you can provide that there. Also, just a reminder to provide any additional feedback that we can incorporate into our summary. We also have some new infographics that are available on our website, and we will continue to be posting those as we develop those. And then we also have some frequently asked questions that are already on our website. And once again, we'll be adding to those as well. There's also a great timeline overarching around behavioral health transformation and the work that's being done here at DHCS. Some really key milestones and areas that we are required in statute to meet, and then also our plan around that. So I'd encourage you to look at those resources. I do want to thank you for joining us today. This is such an important topic. There's, a lot of training and technical assistance that we've heard from you today, and some really great ideas around that we will be rolling out at the department level over the next several years, pertaining to not only integrating substance use disorder services into the Behavioral Health Services Act, but also with other topics as well for our behavioral health transformation. So thank you so much for joining us. We look forward to just receiving continual feedback on this effort, and just want to thank you all for all of the feedback you provided today and over the course of this project. So thank you so much. Have a great day, and we'll be seeing you again soon. Take care.